Declaration on Human Rights has stipulated that everyone has a right to a standard of living adequate for the health and well-being of themselves and their families. This was stated during the Declaration of Human Rights in the United Nations. Following that, the World Health Organization stated that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, and that it also further stipulated that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being. And the world has been engaged in ensuring that every human being will achieve the highest standard of health, and we're working towards that. However, in the progress of years, noting that there was increasing disparities in health between developed and developing countries, in 1978, WHO and 134 countries in the world met together at Alma-Ata, and they declared that it's possible to achieve health for all, and it was time-bound by 2000. And this declaration is known as Alma-Ata Declaration. This declaration emphasized on priority health interventions being delivered to all peoples where they lived and worked. In 1990, the Alma-Ata Declaration that had the essential health services as its targets was also time-bound, and it was supposed to be achieved by 2000. So in 1990s, there was a global assessment on the progress made worldwide by different countries in the north and south, whether this target has been realized or is progressing towards the realization. And it was noted that many of the countries, especially in Africa, were not able to achieve health for all by the year 2000. So they met in 2010, and at that time in the United Nations, they came up with this beautiful idea of the Millennium Development Goals, again time-bound, to achieve a standard of health of individuals, households, and communities by 2015. So they gave a 15-year target for the realization of the Millennium Development Goals. Many of the countries, again in Africa, did not achieve these goals. As it was stated yesterday by Dr. Debror, a few countries in Africa, including Ethiopia, have managed to attain some of these goals. And some of the reasons that were considered as attributable to this failure to achieving the goal was that developed countries who had committed to give 77% of the GNP towards the realization of this goal, most of them didn't deliver that. So it was both a failure by the developed countries, failing to meet their commitment, as well as by developing countries, the same. So in 2015, there was, again, an assessment of whether the world has achieved the commitment that it has made. And again, disappointingly so, many of these goals were not achieved. So again, nations got together as a nation individually and collectively to assess what the reasons were. And now we have the current millennium, the Sustainable Development Goals that takes us to 2030. And both the Millennium and the Sustainable Development Goals focused on poverty reduction as one of the central focus towards the achievement of these established goals. Ethiopia, being signatory in the United Nations, is also committed to these goals and has been trying very hard to achieve these goals. So now, these goals were primarily, especially when I'm addressing the issue of public health. And public health, right from the beginning, was focused on multi-sectoral determinants of health as impacting on health of populations and individuals. I know there is a definition that I almost have studied by heart, but, which was on public health practice. It was defined by Charles Edwards Emery Winslow. He said that public health practice is characterized as the science and art of disease prevention, prolonging life, and promoting health, as well as through organized community efforts for the sanitation of the environment, the control of communicable diseases, organization of medical and nursing services, early diagnosis and prevention of diseases, the eradication of education of individual in personal health, and the development of social machinery to assure everyone a standard of living adequate to the maintenance or improvement of one's health. So it is, one can see right from the beginning, it was in 1920, that the realization that health is a multi-sectoral phenomena, health is a community phenomena, and the achievement of health requires the active and systematic engagement of all professions and disciplines in health. Now I'll take you to the evolution of public health in Ethiopia. In Ethiopia, public health started as an organized institution in 1948 when the Ministry of Health was established. At the beginning, it focused on reconstructing facilities and institutions that were destroyed by the war. And in 1953, the University College of Addis Ababa opened its medical school, and Ethiopians who were studying abroad were called to come to Ethiopia and continue their medical education in this new facility. Other training facilities in pharmacy, nursing, and other disciplines were also initiated subsequently. In 1954, the Gondar Public Health College was established as a training center of a team of health workers, health officers, nurses, sanitarians, and laboratory technicians to work as a team and provide services in the rural communities. During the establishment, soon after the establishment of the Ministry of Health, by 1953, the coverage was considered to be around 25% of the population of 15 million people at that time. Between 1954 and 73, basic health services was considered as a strategy of health service delivery, and this focused on establishing health centers, health stations, and clinics and hospitals as well, to address the health needs of the population, both in urban and in rural communities. Specialized services, such as eradication of leprosy, sexually transmitted diseases, smallpox, and so on, were also part of the health services delivery. By 1974, at the end of the basic health services era, 85 hospitals were established, 93 health centers, and 650 clinics were serving the Ethiopian population. This was followed by another phase in the health services delivery strategy, which covered the period 1974 to 1991. This is considered as the primary health care period in the health service strategy. As I said earlier, at Alma-Ata, countries got together and decided the achievement of health for all by the year 2000. Ethiopia embarked on services such as HIV/AIDS, malaria, and tuberculosis control programs, and other related programs in the country, including expanding services to the rural population. Community health workers and traditional birth attendants were trained and deployed to support the health services that were established in the various tiers. However, this period marked a significant negative impact because of continued recurrent famine and prolonged internal strife that destroyed many of the health facilities, and moreover, it also led to the exodus of many health professionals who were not happy with what was going on in the country. And by the end, in 1974, Ethiopia's government became a military government, and the military government took power in 1974 to 1991 was the period of primary health care where the military government was in power. And at the end of the military government in 1991, because of the recurrent famine and drought and prolonged internal strife, the health services also were completely diminished, we can say. Now, this was followed by, again, another strategy in the health services, in national health services, that covered the period 1991 to the present, and this was also led by the EPRDF administration. The EPRDF focus had been decentralization and transformation in the sector. The decentralization had both negative and positive impact on health services delivery. I'm not going to go into the details, but that had significantly affected the country's health situation. The sector, through time, prioritized the four pillars: health service delivery, quality improvement, leadership, governance, and health systems capacity strengthening. A specific emphasis is given to Warada and household level programs. Then Ethiopia again went into the modernization of its health services, including introducing the Grand Challenges program that was launched by Bill and Melinda Gates in 2003. Ethiopia's Grand Challenges had identified selected areas that were focused on child health, maternal health, pastoralist communities, and this was because the government, the ministry, decided that this focus would lead the country to the achievement of its sustainable development goals. Now, Ethiopia is trying to engage in improving its technological capacity to improve its health services. And a few areas has been attempted through these programs, and some of the programs that were considered as part of the strategy for improvement of coverage and quality of services were considered to have minimal use of technology. So we feel that Ethiopia can improve its technological uh, use through improving the digitalizing information of the health sector, the fast-track expansion of mobile services, and improved internet connectivity, which is at its lowest right now. The use of solar energy is another area that can enhance facility level efficiency and effectiveness, because we claim that we have 13 months of sunshine. However, we are not making use of that. And the expansion of telemedicine and network for information solution is another area that the sector can use, but is not using right now because of several reasons. We also know that massive use of technology to improve excreta disposal, environmental sanitation, water safety can be done, but it has not been done. Proper identification, testing, standardization, and coding of traditional medicine is another area where technology can enhance Ethiopia's health services, but there is also shortage in that regard. The untapped rich biodiversity resources could be used in the further development of, again, traditional medicine, where countries like China and India have made maximal use. Biotechnology application is another area that we can also consider. However, that is not being practiced significantly or to an appreciable level in Ethiopia. But we want to take Ethiopia to the next level by introducing technology, expanding technology, and making significant use of technology to enhance the services. In fact, yesterday I was listening to the speakers about the potential of robotic technologies that we can use in the sector. And this and similar technologies are expensive, and our country, in terms of its technological advancement, is at its lowest to be able to make maximal use of the services. Now, I have few recommendations to make. One, I feel that advocacy for increased awareness and commitment of policymakers and service providers on the power of expanded communication technology in reaching remote communities should be further and strongly advocated for. High-level commitment and investment in human capital and financial resources will be required, but the government has to make commitment to ensure that these things are made available through partnership and other means. Increase in national capacity to ensure universal access to functioning and affordable internet technologies is something that the country can utilize, but for some reason, our policy in internet connectivity and use has been rudimentary. Clear and strong partnership between professionals in the country and professionals abroad is another important step that need to be emphasized for knowledge exchange and technology transfer. And looking at the participation here between professionals, technologists, and in the country and abroad, one can see the potential that we have in terms of mobilizing this immense resource. However, we need clear policy on all these. We do not have those. Abide, as I said, an organization established for the engagement of professionals in the diaspora should work more actively in engaging the two professional groups for higher and sustained knowledge exchange and capacity building. We also heard this morning that the ETRSSI, the first Ethiopian satellite, could provide another source for the realization of the enhancement of the use of technology in the health sector. My final recommendation is that the progress of the Ethiopian 2050 Grand Challenges Initiative must be regularly monitored and findings disseminated for accountability and improvement of the delivery of services. Thank you.